The sun rises over the San Joaquin Valley, California. Today is March 18th, 2020. Last week marked the 5th anniversary since we opened our home at East Niles Community Health Center. The grand opening was on March 6, 2015. Also, Match Day 2020 is coming soon. We are happy to inform that we matched all 8 positions. We will know the residents' names in a few days. This will be our 6th class. We are excited to welcome a new group of motivated residents starting in June 2020. Also, COVID-19 has infected over 200,000 and caused almost 9,000 deaths worldwide. Yikes. Yesterday, a non-resident in Kern County was tested positive for coronavirus. This pandemic continues to evolve every day, but we will not talk about it any further today. Visit the CDC website or contact your local public health department for accurate and updated information.
Welcome to Rio Bravo Q Week, the podcast of the Rio Bravo Family Medicine Residency Program, recorded weekly from Bakersfield, California, the land where growing is happening everywhere. The Rio Bravo Family Medicine Residency Program trains residents and students to prevent illnesses and bring health and hope to our community. Our mission is to seek, teach, and serve. Sponsored by Clinica Sierra Vista, we are providing compassionate and affordable care to patients throughout Kern and Fresno counties since 1971. If you think education is expensive, try ignorance. Ann Landers.
Headache is among the top 10 chief complaints among primary care visits. We're happy to address this relevant topic today with one of our chief residents. Today, our guest is Lisa Manzanares. Lisa is on her 3rd year of residency, and I'm pleased to see you today, Lisa. By the way, she has also been the voice of our Speaking Medical section every week. Welcome, Lisa. Thank you for being here. Our podcast has 5 questions, as you know, and we'll start with the first question. Very simple. Tell us who you are.
Hey, I didn't know this was an interrogation. All right. You want the short or the long answer? So I have to talk for 20 minutes, they say, so you're going to get the long one. I'm a U.S. Navy veteran, a mom of 3 little girls, a wife, a rock climber, explorer of the Sierras, longboard enthusiast, and a 3rd-year family medicine resident in the Rio Bravo Family Medicine Program. I took the circuitous route here. So after graduating medical school in 2013 from Western University of Health Sciences in Pomona, I did an intern year at the Naval Medical Center in San Diego. After that, the Navy sent me to the Central Valley in Lemoore, where I practiced outpatient general medicine as a GMO, not a genetically modified organism, a general medical officer. So I took care of active duty members and their families while stationed at the Naval Hospital Lemoore.
That's a very nice bio, Lisa, and thanks for being here. We're very happy to have you as one of our residents. We're very proud of you for all your accomplishments, and I think everybody is enjoying your working with you. So our question number 2 is the main part of our podcast, which is what do you learn this week?
So this week I learned about the acute treatment of cluster headaches in the clinic. 100% oxygen via non-rebreather facial mask with a flow of at least 12 liters per minute. You should continue at least for 15 minutes to prevent the attack from returning, though the patient may feel better really soon in as little as 5 minutes. As for medications, you can use sub-Q sumatriptan 6 milligrams, or which is beneficial in about 75% of patients. Intranasal sumatriptan or zolmitriptan can be used, but it's slower in onset. So you can actually use 3 milligrams of sumatriptan sub-Q in some patients. It's beneficial. And the intranasal triptans are administered contralateral to the pain side. And this is because patients with cluster headache often have rhinorrhea and congestion on the side ipsilateral to the pain. impeding the delivery of the medication. So one thing that's different about another one of the medications is that intranasal lidocaine in a 4 to 10% solution can also be used and is effective in about a third of patients. The lidocaine is administered on the ipsilateral side.
That's interesting. So the triptan, when it's intranasal, is in the contralateral, and the lidocaine is in the ipsilateral side of the symptoms. Excellent. I like that information. I didn't know about it. So the good thing about knowing this is that we can treat our patients who are in the acute pain, but sometimes we don't see the patients on the acute pain of the cluster headache. But if we do, now we know the treatment: oxygen, triptans. But if you see a patient with a chronic cluster headache, you have to administer prophylactic medication we were going to talk about later. Cluster headaches is more prevalent in men and typically begins between 20 and 40 years of age. Another name that we can include in our medical word of the day is trigeminal autonomic cephalgia, which is unilateral, is located on the temporal or periorbital area, is accompanied by at least one ipsilateral symptom in the eye, nose, or face, such as rhinorrhea, conjunctival injection. It causes restlessness or agitation. The duration is between 15 minutes to 180 minutes. You can imagine how bad the headache is if it lasts that long. But one episode can be every other day to 8 episodes per day. So it can be very disabling for many patients, and it's a very severe headache. I just want to tell you an anecdote about one of my patients. He came to our clinic when I was a resident, and he explained to me how bad the headache was, and the way for him to make me understand how bad it was, he put a pen on his eye, and he stabbed his eye. He stabbed his eye with the pen to show me that he had a really bad headache. It was not the acute headache. He was explaining to me how bad it was when he gets a headache. So I explained immediately that it was a cluster headache. I was lucky that he only injured like the immediate aspect of his eyelid, but it was a really graphic explanation. So you can see how bad the headache can be. Tell us about the prophylaxis, Dr. Manzanares.
Whew, a pen in the eye. Yeah, you definitely want to prevent a headache that terrible. So as for prophylaxis of cluster headache, verapamil is a first-line therapy. Other meds that aren't first-line but may work include glucocorticoids, lithium, topiramate, and then there's more invasive treatments such as nerve stimulation or surgery in refractory cases. So in the primary care setting, we're going to primarily be using verapamil.
Okay, very good. Excellent. So that takes us to our question number 3. Why is that knowledge important for you and your patients?
So it's important because cluster headaches are miserable. In fact, the pain is described as a severe suicide headache under diagnostic criteria in journal articles on a cluster headache. So our jobs as family physicians are to reduce common miseries, and about 1 in 1,000 U.S. adults has experienced a cluster headache, and cluster headaches has a large associated morbidity. 80% of these patients report restricting daily activities, such as calling out of work and canceling stuff. So common and miserable is something that we need to learn about for the sake of our patients. Plus, oxygen is something that is in every clinic. This is one way to be able to treat the patient on the spot and have them walking out of the clinic feeling better.
Excellent. So what have you heard anything about like the triggers of the cluster headaches?
Yeah, a lot of things can trigger it. Vasodilators such as alcohol, nitroglycerin, that little blue pill, histamine, tobacco exposure, so first or second hand, and sleep disturbances, so jet lag and sleep deprivation, switching shifts, stuff that residents have to do all the time.
Mm-hmm. Yep. So now we know about the triggers. Tell us about how do you get that knowledge?
Well, so there's always that question about 100% oxygen and cluster headaches on the boards and the shelf exams. So that's probably not news to anybody listening to the podcast. So the oxygen thing was something that actually stuck from med school. Actually setting it up, though, in the clinic and knowing to put on a non-rebreather and, put it at 12 liters, that was something that I learned from our faculty. So my trusty sources in clinic are number 1, up to date, number 2, faculty, actually number 1, faculty, number 2, up to date, sorry. And then review and journal articles. So yeah, that's how I found out about that.
Oh, great. So tell me the resources that you used to get this knowledge.
This information is an amalgam of knowledge from Dr. Schlereth, our faculty member here. Cluster headache article by Dr. Weaver, downloaded from the AAFP website, and cluster headache treatment and prognosis on Up to Date. So,
okay. Yeah, and we have the details in our website. So if you wanna read more about this cluster headache, so I invite you to see our website. Now we conclude our episode number 3. I don't know if you were mentioning something about the suicide headache. It was somewhere in your submission to me, but that's the way they describe this headache, right? Because it's so intense, it's so bad, that it's called the suicide headache. Cluster headache is no joke. When you encounter a patient with a cluster headache, remember to use oxygen and abortive treatment, such as the one that Lisa just explained to us. Don't forget to prescribe prophylaxis treatment if necessary. Thank you so much. Lisa, any other word about cluster headache?
no, treat it so people don't stab themselves in the eye with a pen.
Okay, good job. Thank you so much, guys, and stay tuned. We'll see you next week.
Hi, my name is Dr. Kumar. Today, I want to teach you the medical word of the day. Since everyone is fighting over toilet paper, we thought it was only appropriate to introduce to you the explosive medical term of the week, steatorrhea. Steatorrhea is excess of fat in the stools, often due to the impaired transport of nutrients across the apical membrane of the enterocytes that results in oily, foul-smelling stools. Some of the underlying causes of steatorrhea are celiac disease, cystic fibrosis, pancreatitis, lactose intolerance, and gastrointestinal infections. If you see a patient with steatorrhea, not caused by the consumption of unhealthy amounts of burger and fries, please investigate further by asking onset, duration, frequency, triggers, and travel history. Perform a complete physical exam and order additional studies based on your assessment. In young children presenting with failure to thrive and steatorrhea, do not forget about cystic fibrosis. Remember the medical word of the day, steatorrhea.
And now, Spanish, por favor, our Spanish word of the day.
This is Dr. Fernandez, and today's Spanish word of the day, which is piquete. Piquete is translated as a prick, shot, jab, injection, or a stinging pain or discomfort. The scenario where someone would use a word like this would sound like this. O doctor, me da un piquete en el pecho. Or, doctor, me da un piquete en las piernas. It means, doctor, I have a shooting-like pain on my chest, or, doctor, I have pricks on my legs. People can use this word to refer to acute, sudden, short-duration, stinging, sharp pain. It is like a bird bite. The etiology of this pain can be very broad and can include muscle spasms, neuropathies, leg cramps, or many other conditions. It may also be a sign of no disease at all. Now that you know the Spanish word of the day, piquete, all you have to do is go assess your patient's piquetes. That's all for today. Have a great week, and remember to wash your hands, avoid touching your face, and avoid crowded places. Thank you.
And now, for your sanity.
Why did the teacher with tertiary syphilis get fired?
Why?
He couldn't control his pupils.
What is an EKG finding of hypospadias?
It doesn't make sense. What does an EKG show in hypospadias?
Inverted P waves. A family medicine doc, an internist, a surgeon, and a pathologist are out one day duck hunting. First up is the family doc. He raises his gun to take aim at a flock of birds passing overhead and says to himself, "It looks like a duck, flies like a duck, quacks like a duck. It must be a duck." Bang! He bags himself a duck. The internal medicine doctor then steps up, raises his gun to take aim at a second flock of birds flying overhead. He says to himself, "Looks like a duck, flies like a duck, quacks like a duck. Rule out quail, rule out pheasant, goose versus duck, likely." Bang! He too bags himself a duck. A third flock of birds and flies overhead, and the surgeon steps up, raises his gun at the flock. Bang, 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 bang. He fires multiple rounds at the flock, and the dead birds are dropping all around. The surgeon lowers his gun, walks over to one of the dead birds, picks it up, hands it to the pathologist, and says, "You tell me if this is a duck."
And that's the end of Rio Bravo Q Week. We say goodbye from Bakersfield, a special place in the beautiful Central Valley in California, a land where the growing is happening everywhere. If you have any feedback about this podcast, please contact us by email, rbResidency@clinicasierravista.org, or by visiting our website, rbfmrp.org/QWeek. This podcast was created with educational purposes only. Visit your primary care physician for additional medical advice. Our podcast team is Hector Arriaza, Lisa Manzanares, Roberto Velasquez, Greg Fernandez, Monica Kumar, and Simran Gill.